Welcome to Health System CIO's interview with Dr. Rob Bart, CMIO at UPMC. I'm Anthony Guerra, founder and editor-in-chief. Dr. Bart, thanks for joining me.
Anthony, thanks for having me and asking me to join you this afternoon.
All right, very good. So today we're going to talk about enterprise imaging. We're trying to bring some stories to light of people who are doing work in that area, maybe having some successes and working through some challenges. So let's start off first. If you want to tell me a little bit about your organization and your role.
I am the Chief Medical Information Officer here at UPMC. I am responsible really for the functional use of any of the clinical systems here at UPMC. UPMC is both a healthcare delivery as well as a payer organization, about a 50-50 split in revenue. I think we'll approximate about 28 billion this year. Over 40 hospitals, over 700 acute care delivery sites, predominantly in the state of Pennsylvania, with a small outpost in Western New York and another one in Western Maryland.
All right, excellent, very good. So, as I mentioned, the what we want to talk about here is um, a push. We call it enterprise imaging, although I'd love to hear your definition of that if you have one. But generally, a push to make images more readily and easily available to clinicians across different specialties, across the enterprise. So, we know this is an area that can be difficult for patients and clinicians with CDs and things not being readable. And patients have a lot of the onus on patients to sort of figure out a way to bring their images with them all over the place and then make sure things can be viewed. There's a lot of fits and starts, I believe, that come up with this in the care process. So I'll stop there and you can just jump in and we'll go from there.
Okay, thanks, Anthony. So. I think historically, when healthcare systems talked about enterprise imaging, they were predominantly referring to picture archive systems. They're usually specific for radiology images, occasionally for cardiovascular imaging systems also, which are frequently centralized. But I think the early definitions certainly didn't include all of the other specialties that do diagnostic studies and/or interventional studies that also generate images. Whether it's gastroenterology or pulmonary with bronchoscopy or pathology, as it even moves more and more into the digital world today. So as I think about enterprise imaging, it goes back to even before I started here at UPMC. I started in the summer of 2017 and really thought about what are all the images that really entail a patient's imaging jacket, so to speak. If I reflect on sort of the electronic health record world, if you think about it, one of the goals of that has been to be able to create a single consolidated digital electronic record that's text-based of all the information on the care of a patient that's been delivered. And I think conceptually, I've taken that same thought and applied it to why can't we create a single imaging jacket? There's a one-for-one relationship of that patient who's receiving care at the healthcare system and all of the digital images that are obtained related to their care. And from a consumer patient perspective, it should be as simple as I go to one desk or make one phone call or one patient portal request that says I'd like my complete record. And that complete record should include all the text-based documentation as well as all the image-based documentation or images that we have on them. That's not something, if you go to any healthcare system today, I don't believe anyone achieves that easily or well.
Mm-hmm.
No. If you add on top of that the, CARES Act and information blocking, a lot of people talk about information blocking as it relates to what is traditionally text-based documentation and the EHR, but information blocking requirements also extend into images. and making sure that patients and consumers have access to the images of their care. So if we're going to solving that for patients and consumers, we should also be able to solve and improve the workflow for clinicians with the same solution. And that's really the goal here. Can we make it easier both for clinicians who need access to this information to effectively and efficiently deliver care? And then can we also then in turn have that solution serve for patients who need easy access to the information on the care or even the health of themselves as they're trying to review that information?
So how do you move forward? I mean, it it seems like every health system is going to be very different in terms of well, they're all going to be using the same modalities, but they're going to have different vendors. You're going to have different PAC systems, um, different usage of images in different special. How do you start? Is there a general principle that says, okay, we want to move towards an enterprise imaging paradigm. Therefore, here are the 3, 4, 5 things we want to work towards. Like, how do you start?
Yeah, so I actually think so. First, it's defining what enterprise imaging is. And as I said, I think it should be a single container that has all of the images that pertain to any patient's care. And in this instance, it would be any patient's care at UPMC. The container that a lot of people use, and I think what we're going to use is a vendor neutral archive, which allows us to bring in images from all types of modalities of acquisition, regardless of the specialty that uses the device. I think that one of the barriers is the change management on who sort of, I'm sort of air quoting here, but who owns the images. Historically, images have been used for that specific group of clinicians that are involved in the acquisition of them or ordering them. So I'm a pediatric intensive clinic by clinical training, and I order images and rely on the radiologist for the interpretation, but also look at them and also make sure that interpretation marries with the differential diagnosis I'm working on, right? And so that's a collaborative process. And so radiology has always been involved in a very collaborative process.
Mm-hmm.
If you go to the next area where the largest number of images tend to be generated, that's cardiology. Those images tend to be ordered by the cardiologist who's consulted, and then the consumption of those images is either the cardiologist or the cardiac surgeon most frequently. And so that's a fairly closed group of people, right? But
Mm-hmm.
then in an ICU environment, frequently I need also to have access to those images and the reports of those images for the management of a patient in an ICU. And so it starts to get larger. And so there's a change management and working with the different physician or clinical specialties. And they need to get buy-in and understanding that the images do serve their needs, but they serve the broader medical community. And that's why it's important to move into an enterprise architected picture management solution, like a VNA,
Mm-hmm.
because you need to get them to understand the why of the approach and what you're trying to do. And I think it also becomes somewhat serving to that group. If you take gastroenterology, our gastroenterology group spans a very large geography. And so we want to make sure that the images acquired at a single location are available to that group across all the venues of care that we have. And so one of the incentives is, as UPMC has grown, as other healthcare systems have grown, their access points may not be just the place that they acquire them in that GI suite today. It may be that they're seeing that patient across the state where the patient originally traveled from, and they need those images there. So we can meet their clinical needs that way. But also it's really getting them to understand that the broader community of clinicians need to see those images. I think once you solve that, then you get into an ability of moving those images into a VNA through the change management approach that I just mentioned. And then once you get them into VNA, then serving them up to the broader clinical community, as well as being able to serve them up to the patients, becomes much more realistic.
So obviously clinical care and the needs of clinical care have not changed, right? So in the scenarios you're offering, the clinician you mentioned who's not in the smaller circle in your cardiology example, and you were saying referring to yourself perhaps wanting to see that image,
Mhm.
that is sort of from an application or access point of view, it's in the circle of cardiology, but you want to see it. You
Right.
always wanted to see it and you still want to see it. But now you're saying, as an enterprise, let's do something about this problem because I can't see it. I can't see it easily, or it's difficult for me to see it. So let's move into a paradigm where all clinicians who possibly want to see an image can easily see it rather than having to bend over backwards or jump through hoops. And therefore, if we're going to change the workflow, we're going to change the paradigm for the cardiologists, we need to tell them why. We need to explain to them that, hey, I like to see this too, and it's really hard now. So we're going to do some things, they're going to change some things. Things are going to be different for you. You're going to access the images differently. But the upside is I can see it now, and that's good for the patient. Does that make sense?
That I think how you stated that is exactly right. Right. The ultimate goal here is to improve the efficiency of the clinicians involved, but also the effectiveness with their ability to deliver care. And as someone, going back to the cardiology example, early in my career, I worked in a pediatric cardiac ICU. So I took care of children who either were going to or have had cardiac surgery. And so got used to looking at cardiac imaging like echocardiograms, um, working very closely with cardiologists. In the early days of, you know, I used to have to go to what was called either a heart lab or a heart station or a cardiac lab to actually review the images, but really could only do it if I was physically side by side with the cardiologist at the time, right? Now I have the ability to view those independently on my own. And then I can reach out to the cardiologist if what I'm seeing and what their documented interpretation, if I have a question or a concern or thought about it. Sometimes they may not have the full clinical context of the patient at the time that the study is done. And I want to make sure that they're aware that when this study was done, the patient was on certain medications or was in a certain phase of their illness, like in septic shock or something of that nature. And we can have a dialogue that's, I think, much more enabled to be useful by me as a clinician, and therefore also valuable to the patient because I have actually active ability to view those images in near real time, in a process that's relatively convenient for me, as opposed to the days when I had to go find a cardiologist and go to the heart station to review those images with them.
So the scenario you just gave, so you talked about the old days when you had
Right.
to sit at the cardiologist station. The scenario you just gave, is that the VNA scenario or is that the pre-VNA
That's
scenario
so
where
in
it's going to
today's
get even
world,
better with the VNA?
that's pre-VNA, right?
So you're logging into their PACS system?
Yeah. So I'm
Okay,
logging
so
into their cardiovascular imaging system. Yes.
so you can do it, but it's not the end all be all state. The VNA is sort of, I don't know if you want to call it the nirvana state, but it is beyond the current. I have to log into their packs. It's even better than that, correct?
Yeah. Yeah. It is. It's even better than that because um, it's sort of one-stop shopping for all the images of a given patient. They're all within that patient's jacket, whether they are obtained by cardiology or gastroenterology or pathology, um, bronchoscopy. And so my ability or any clinician's ability to then look at all these images that may be important to decision making with care of a patient, I have that now at my hand, as well as the context of everything as it relates to the electronic health record.
Mhm.
right? And
Mhm.
so having that all together in sort of one pane of glass, so to speak, in front of me, allows me to have a better picture and understanding of the patient, and should enable better decision making or more efficient decision making, on behalf of the patient. And that's ultimately what we're trying to do, is to simplify the task burden of the clinicians by bringing all the information together. And let's decrease the task or the cognitive burden of the effort there. So the focus is really on figuring out what is the best approach or the best care for the patient I can deliver them.
So would you say that you have your VNA in all the packs? So it comes out of the modality, and again, tell me if I'm wrong. Comes the modalities take the images, they go into pack systems. You know, all different pack systems. We're gonna get all those images moved to the VNA. Okay,
Correct.
so now you've got the VNA for all the images. You've got Epic for sort of everything else. Help me understand the integration, or if there is any, between the VNA and Epic from a physician point of view. You know, I understand we want all roads to lead to the EMR. So tell me about the relationship between the VNA and Epic in this case.
So there's, I think there are a couple different ways you can do that. The simplest way that images tend to be integrated into electronic health records like Epic and others is a context-aware launching into that image from the electronic health record.
Hmm.
So if I want to look at, I'm in a patient's record, I want to look at the chest X-ray from today, I might have that report, the chest X-ray report in front of me. I can launch into that. It carries the context of the patient and my login into the either the PACS or the VNA,
Hmm.
and I can look at that image, right? So, but that's conducive of if in that case I need to look at one or two images. If I want to look at a whole series of images, let's say I admit a complex patient who's got a long history with our healthcare system, has a long or a large imaging jacket with multiple images. The other way that people link them is through an HL7 construct called CMIO, which is, again, context-aware mapping, but it actually allows me to have the electronic health record and the full patient jacket up at the same time. And because then I may want to navigate from the patient jacket and say, well, I didn't know that this pathology result that was there. Let me look at that. Or I didn't know, why did this patient have so many brain MRIs in 2021? Right? That may be pertinent to the care I'm delivering.
Hmm.
So there's a couple of different ways. The important thing I think that's important in either of these is making sure that it's context-aware linking,
Mm.
so that the patient context is moving and the authentication of myself as a person happens seamlessly, so I don't need to log into multiple systems.
Yeah, I mean, obviously you used a great expression before, cognitive load, right? And
Yeah.
that's what this is all about. This is all about figuring out the best way to bring information together onto a screen so a human being, I mean, right? So
Mm-hmm.
like, you know, and you have to take these things into account, right? What's the form factor that this physician is looking at this information on? Because if it's three giant screens, it's different than if it's one normal 17-inch laptop screen. What are we planning for? Because if we plan for three giant screens and we're really giving it to them on a 17-inch laptop, that's where they're looking at it. Those things don't line up, right? We're human beings. We could take in a certain amount of information. So I'm sure you have all kinds of committees, and the vendors do a lot of these things that some of that is out of your control. Some of it may be in your control. Some you can influence. You probably have committees figuring out how do we want to see things, how do we want to tweak workflow, just wherever you want to jump in there.
Yeah, so typically most of our clinical workstations are single monitor workstations with usually a 24-inch high resolution monitor on them. There's many of them are computers on wheels, and so there's a practical size that you can have.
Yeah.
But in most of our care delivery by nursing unit speaking of like a hospital situation, there is usually at least one location where you have higher quality monitors with multiple of them for reviewing images in that location.
Hmm.
You know, going back really to the when I started care, the old days, it was right going downstairs to radiology because it was film that you were looking at. And so, what we're talking about and what you're asking about with enterprise imaging, I don't know if people would view this as 3 or 4 generations beyond the old film model, but you need to have high quality glass within the framework of where clinicians are delivering care to review certain types of images. Um, Even a high-end laptop monitor might not have the type of contrast you need. A good example is sometimes a pneumothorax, which is air that is outside the lungs but inside the rib cage.
Hmm.
Right, a pneumothorax can be challenging to see depending on if you have the right lighting and the right type of monitor to review the image on.
Hmm.
And we want to make sure that it's not only efficient and convenient for our clinicians, but we want to make sure that we're providing them with viewing stations that give them that ability.
Right, and they're not all the same, right? So
Right.
a station that's intended for looking at images, and then you have different kinds of viewing, right? There's diagnostic viewing, meaning I'm making a diagnosis here, or I believe it's referential, where I'm just looking at it and I'm not actually reading it, or I'm not making that sort of legal clinical evaluation, right? Because you can't, if you're reading an image for a diagnostic purpose and the monitor is not up to the requirements, that's a problem, right?
Yeah, yeah,
Yeah.
you're absolutely you're correct, Anthony. I think we need to separate. So, diagnostic image reading is really the domain of the specialty that's acquiring it, right?
Mm-hmm.
Radiologists, and the highest order of that is in breast imaging, there are strict guidelines as to the type of monitor, as well
Mm-hmm.
as the amount of ambient light in the room when
Wow.
you're doing a diagnostic read.
Mm-hmm.
And but and that and you want to make sure that the gastroenterologists, the cardiologists, they have good reading stations that meet their diagnostic requirements. Most of what I do and most of the other clinicians who are not acquiring the images are really doing a referential read
Yeah.
and really want to be able to confirm what I see on this monitor in front of me and what I read as the interpretation from whoever performed the interpretation on a diagnostic quality image. Does that actually line up? If I don't quite see it eye to eye, then that's when I need to track down whoever authored the report and maybe go and visit them and actually on their diagnostic monitors review the images with them to make sure that I understand what they're seeing so that I'm making sure I'm interpreting things appropriately to make the best decisions for the patient. But
Right. So let's
predominantly what I'm
go ahead.
doing and what other clinicians have said, it's really about referential images reading.
Yeah. So you mentioned the VNA as sort of, I think, a key strategic decision of how you were going to move forward in this image sharing world. So were there other options? Is sort of the VNA the no-brainer? Is that absolutely the way to go? Or were there other options and we decided to go with the VNA option for image sharing?
Um, you know, I, I I think the vendor neutral archive, at least at the time we made that decision, there weren't other options to consider. There were only brands of VNAs to consider. But the idea around the vendor neutral archive is it's not limited as to the type of image it can import into it for storage,
Hmm.
right? You know, and most people understand sort of in radiology or even in cardiology, DICOM as a sort of a wrapper that
Mm-hmm.
wraps that image. VNAs can support DICOM images, but they can also support non-DICOM images like JPEGs, TIFFs, and MPEGs. And so, they're it's a vendor neutral. It's like
Yeah.
a universal archive of
Hmm.
imaging. Um, are there flavors of those, and will they improve over time? I think that's absolutely true. But I think conceptually, it is probably the broadest and most generic perspective
Hmm.
on a system that can be used to collate and acquire all of the images in healthcare.
So where are you in this journey to sort of free these images from the individual PACS systems that they live in and get everything migrated to the VNA? Where are you in that journey?
We're extremely early in on it.
Hmm.
I think, as you're aware, Anthony, UPMC is partly an organically grown healthcare system, but also one that has grown through merger and acquisition.
Hmm.
So on the radiology side, we're in the process of implementing an enterprise PACS system for radiology images. We have more than one PACS system today. So there's two things we're trying to work to and accomplish here within radiology is to move everybody to a single PACS system while also moving to a PACS system that's got a more modern architecture.
Hmm.
Um,
Okay,
we're
go ahead.
also we're also in the process of moving our cardiology imaging repository onto a singular platform. And so I think the first step in this is consolidating the acquisition of images within each discipline
Hmm.
onto a single platform for
Hmm.
acquisition, right? And then once we have that, then taking the images out of each of those storage modalities and pushing them all into the vendor neutral archive or VNA.
Yeah, that makes a lot of sense. I have heard that it can be quite it's okay. So we use the Epic example, right? Um, Almost always when an Epic hospital or health system acquires a hospital that is on a different EMR, they're certainly going to no longer be using that EMR, and all that information is going to be migrated to Epic. We see it all the time. From my understanding, it doesn't really seem to work that way all the time in the PAC space because of the heaviness and the size and of the images that migrating everything out, at least for maybe for large health systems it's different where you have the resources to do that. But I've heard from other health systems, maybe the ones that are smaller, that sometimes that's just not going to work. Sometimes it's better just to leave them where they are because migration is very expensive, very difficult. Do you have any thoughts around that?
Um, it is challenge. I do agree with overall the perspective that probably that larger healthcare systems have more resources available to extend and look at the migration of images. Um, we are going through the migration process now. It can be a challenge, but at the same time, um, the goal is to make sure we only have a copy of, right? We don't want to have the same large image represented in multiple systems. You're paying the storage cost multiple times. And if if an image in a patient who had cancer diagnosed a decade ago is still pertinent to what an oncologist is doing for therapies today, or if there's unfortunately a recurrence in the future and it's pertinent to have that, we want to make sure it's available to our clinicians with ease. Our ultimate goal is to try and migrate everything into single platform. But how fast we do that is going to be somewhat limited by both technology and the expense of it. But the goal is, the ideal state is to migrate everything. Whether we actually achieve it, there's some realistic limitations and much of that has to do with finance. The technology to do the migration pretty much exists.
Hmm. So would you say, I mean, I just want to make sure I'm thinking of this right. So it's like almost a step one, a consolidation of packs to make sure maybe you have one in each specialty as opposed to three, four, whatever. And then there would be a second migration to the VNA.
Yeah.
Okay, go ahead.
Yeah, no, I think your summary is appropriate.
Okay.
You know, I think we're trying to move more and more of what we do clinically when it involves any technology platform into single enterprise instances, whether that's radiology pack system, cardiology pack system, gastroenterology imaging, bronchoscopy, etc. Because having a singular platform allows us to actually then also make sure that we're delivering a single standard of high quality care across our system. Eliminates redundancy, it eliminates multiple contracts on many levels. Having a single platform that is the right platform for UPMC really achieves a lot of the quality and operational goals that we have. And then once we have that achieved, then and can serve the immediate needs of the group of clinicians that's involved specifically in why that imaging needs to be obtained and utilized diagnostically, putting it into the VNA then allows broader access and for all of the clinical community.
We're almost out of time, but just maybe a couple more quick questions because this is good stuff and I appreciate your time. Um, you had alluded to it before that a lot of times the hardest part with this stuff, it doesn't have anything to do with the technology. It's the human beings that we're asking to do things differently than they have done them in the past. And that can be
Mhm.
challenging. And you explain that adding the why, explaining the why can go a long way to getting buy-in. Um, any advice, any more advice around that you want to give your colleagues who are going to be moving down this road? You're a physician, obviously, you're the CMIO. Um, Almost every CIO who's working at an organization of any size will have a CMIO to partner with
Mhm.
on this, which I'm sure is exceptionally helpful. That's why the position exists, because physicians like to hear from physicians as opposed to techies. But your thoughts there around the change management piece?
Uh, I spend a lot of time trying to work through for any, regardless of project, whoever the clinicians being impacted, whether they're physicians, nurses, or pharmacists, therapists, trying to understand what's in it for them as the organization is trying to accomplish some of the operational organizational goals. And then understanding what that brings of value to them, or making sure that the project has inherent value to them and highlighting that, in my experience, always eases the burden of the transition. It
Hmm.
still doesn't mean that there won't be challenges, and you'll have to work side by side with them through those challenges in the transition. But getting them to understand it up front frequently, in my experience, results in a conversation. Sometimes it's 6 months, 12 months, 2 years later, where they say, I see why we did this, or I understand it now. I think the other thing, that's becoming much more apparent in healthcare is we're trying to meet the needs of two groups of people. We're trying to meet the needs of those who are delivering care, regardless of the degree or initials behind their names. But we're also trying to meet the needs of the consumer and patients who use the healthcare system. And I think getting people to understand that that's the balance we're trying to achieve, right? Let's make it easier for the clinicians while also making it easier for the patients and consumers. If we, getting the clinicians to understand that, how important it is and how competitive healthcare is today as a service in communities is part of the other piece of the equation. I think I look back, 20, 25 years ago when we were building systems, they were frequently to serve the needs of the healthcare system solely from the clinician perspective.
Hmm.
And I think today, when we are building things and working with different platforms that we're deploying, we have to look at the lens of the clinician and then also through the lens of the consumer or patient.
That's excellent point, Dr. Bart, and a great point to wrap it on, because we're just about out of time. But I want to thank you so much for your time today. Obviously, a hugely important issue, for all the reasons you mentioned. So thank you so much.
Thank you for having me, Anthony. I enjoyed the discussion.